Hello, good day everyone. I'm Grace Carlos and I'll be sharing with you my infomercial about a research study that has been done in Eastern Canada. The topic is about being visible or invisible, a qualitative study of queer, lesbian, and bisexual women's healthcare experiences in Eastern Canada. So, please sit back, relax, and enjoy. Thank you.
Being invisible or visible in the clinic, a qualitative study of queer, lesbian, and bisexual women's healthcare experiences in Eastern Canada. They examine the ways in which 18 queer, lesbian, and bisexual women in Eastern Canada negotiated their visibility in interactions with primary care providers. QLB women patients used a number of strategies to determine risk and to be visible or invisible to their healthcare providers. They described participants' disclosure decisions and strategies. And they argue that being visible or invisible requires work on the part of QLB patients in the context of institutionalized heteronormativity. Conceptualizing invisibility or visibility as work is required in efforts to account for and improve healthcare interactions across differences. Care providers are often unconsciously influenced by unexamined heteronormative and gender normative biases. Determining how best to provide patient-centered care to lesbian, gay, bisexual, transgender, queer, or LGBTQ patients remains an important task, especially since the individuals who identify as LGBTQ continue to have poorer health outcomes that can be attributed in part to heteronormativity in healthcare encounters. Invisibility of LGBTQ existence and experience in the clinic is one of consequence of heteronormativity. LGBTQ visibility in the clinic requires explicit discussion between providers and patients about sexual orientation. Clinical guidelines suggest that healthcare providers facilitate LGBTQ visibility by initiating discussions that will allow patients to disclose their sexual orientations. But such discussions are rarely initiated by healthcare providers, and the burden for disclosure often falls on LGBTQ patients.
Although QLB women do not experience unique diseases, their health concerns are not addressed adequately when they are not visible to healthcare providers. Patients who do disclose use more healthcare services and are more satisfied with the care they receive. Patients who do not disclose report lower psychological well-being and are less likely to have trusting and open relationships with their providers, making it more likely that they will not share other relevant information. Methodology. They draw on data from a critical phenomenological study of the ways taken for granted practices perpetuate or transformation of LGBTQ women within the healthcare system. Qualitative interviews were conducted with LGBTQ
Women in Halifax, Nova Scotia, to provide an in-depth examination of their healthcare experiences. This study protocol received ethical approval from the Dalhousie University Health Sciences Research Ethic Boards. Recruitment was conducted through convenience sampling. Inclusion criteria required participants to self-identify as LGBTQ women who lived in Halifax, Nova Scotia. The subsample for this article includes 18 QLB women, 10 of these identified as lesbian, 3 as bisexual, 2 as queer, and 3 as another non-heterosexual identity. Participants primarily white and middle class, which is typical of the reasonably homogeneous population in the research area. Participants range in age from 23 to 73, with 9 in their 20s and 30s, 5 in their 40s, 3 in their 50s, and 2 in their 60s or 70s. As a result, they examined the complex processes QLB women in Eastern Canada engaged into visible or invisible in their interactions with healthcare providers, illuminating the work required of QLB patients in the context of heteronormative care provision. They argued that being visible and invisible requires work on the part of QLB patients in the context of heteronormativity. In the results section, they presented data depicting participants' disclosure experiences, including risk observation and management strategies, approaches to disclosure and remaining invisible, and the consequences of this work. In nursing practice, this burden could be lessened by healthcare providers who facilitate disclosure, as suggested by Baker and Began in 2014. Providers need education to understand why these discussions are important and training in how best to facilitate disclosure. It is important that providers facilitate disclosure for all patients and not just those who appear LGBTQ because these patients may be. Thanks for watching, everyone. I hope this can help this article or this infomercial in our profession as a nursing. Thank you so much for watching.